I'm really excited today to be talking about this case report that I was a part of, specifically looking at gas emboli in bariatric patients during laparoscopic surgery. And we're going to be talking about mainly the anesthetic considerations for this. And so I first want to say thank you to the team that's been a part of this. We have Dr. Brendan Feehan. He is our senior author and the lead anesthesiologist during this case. And Dr. David Fromm, who is the attending general surgeon on the case who's performing the surgery. Both these two attendings are members of the Monument Health Hospital staff. I want to say thank you to Andrew Guyman. He is the corresponding author and was the medical student who was present during this case. And then thank you to Andrew Reuter, who is another medical student. Both of them are at University of South Dakota, and then myself. I have no disclosures, and let's get into it. So just a brief introduction. When we're talking about gas embolization, this is something that's extremely rare, but holds a lot of potential for mortality. It's classically seen in decompression sickness when nitrogen gas precipitates out of the blood due to rapid ascent by a diver. In my first and second years of medical school, this was really the only gas embolus that I was really familiar with. However, as I've gone into my clerkship years, I've learned that gas embolus may also occur during laparoscopic surgeries when CO2 is pumped into the abdomen. So there's really only been one other report of a CO2 embolus in patients undergoing bariatric surgery. And today I present a case where there was a gas embolization in a young female patient undergoing a classic Roux-en-Y gastric bypass. So with careful surgical and anesthetic techniques, the incidence of a CO2 emboli is extremely low, 0.001%, but this still holds a devastating 28% mortality. And so looking at the outline of our talk today, we're going to go over some of the background and significance of this. I'm going to present the case to you all. We're going to look at the anesthetic considerations. We're going to look at what preventative measures can be made to prevent a gas embolus from occurring. We're going to look at what happens when a gas embolus occurs and how is it managed. And then we'll wrap up with a summary. So thank you again for taking some time during your lunch to listen to this talk, and I'd like to get started. So first, since we're talking about bariatric patients, bariatric patient is someone who falls under the category of obese by BMI standards of greater than or equal to 30. So as we know, the obesity epidemic is growing, and with that, we've seen robotic-assisted bariatric surgery has also become increasingly more common. In fact, it's actually tripled in its incidence between the years 2015 and 2020. This has helped make it the gold standard for sustained and treatment of refractory weight loss. So if you've never been a part of a general surgery case or a laparoscopic surgery, you might be wondering, okay, well, what is the role of carbon dioxide during these procedures? So simply put, the role is to provide visualization for the surgeon. This is done by something called insufflation, where insufflation of carbon dioxide refers to the intentional introduction of the carbon dioxide gas into the body cavity. So you can see here, if we have, or here, let me turn this to the laser pointer. We can see here, we place this needle inside and we insufflate the carbon dioxide gas to help provide some visualization. So this is done by, once the air goes in, it pushes the abdominal wall away from the internal organs, and then the robotic camera is able to visualize for the surgeon. So the reason carbon dioxide is used as the gas of choice is because it does not have the same flammable issue that oxygen has, and it's rapidly absorbed by the body and then can be excreted easily by the lungs which makes it something that's nice because it doesn't stay trapped in the body, and something that is nice and easily monitored by the anesthesiologist. Nitrogen has a much harder time, as we talked about in decompression disease. It's not as easily readily absorbed, and actually has a higher risk for a emboli. And oxygen has a high flammability issue. You don't want to be using that for insufflation in the operating room. So now that we've covered some of the background and the significance, I'd like to introduce you to the case. So during this case, we had a 42-year-old woman who was admitted for elective robotic-assisted Roux-en-Y gastric bypass. She had tried diet and exercise modifications along with semaglutide for weight loss. That was done with little success, and so she was a good candidate for Roux-en-Y gastric bypass. She had a past medical history of gastroesophageal reflux disease. She had a small type 1 hiatal hernia, polycystic ovarian syndrome, gout, and obstructive sleep apnea. Her surgical history that was pertinent was a ovarian cyst removal in 2003. And then in 2012, she did have an attempted hysterectomy. However, that was failed due to respiratory distress, particularly when she was placed into the Trendelenburg position. So pre-op with the anesthesiologist. So blood pressure was 150/97. Unfortunately, I do not have her baseline to tell you, but the anesthesiologist was okay with a little bit high blood pressure. The heart rate was 71 beats per minute, temperature 36.7 degrees Celsius. She was satting well on room air, and she had 4 METs. A MET is a ratio of your working metabolic rate relative to your resting metabolic rate. Essentially, it's used as a way for mainly looking at functional capacity. So in this case, she had 4 METs, which means that an activity that has a value of 4 times the energy that you would compared to when you're sitting still. So what does that look like? Well, if you are able to perform 10 METs, that puts you at excellent functional capacity. 7 to 10 is good. 4 to 6 METs is moderate, and less than 4 is poor. And so 4 METs is moderate for a patient with her BMI. That's something that's you're going to have to be okay and good to go with. But METs is just a commonly used metric in pre-op for anesthesiology when they're looking at if this patient's able to undergo surgery. So she then was pre-medicated with acetaminophen for pain, diphenhydramine to help with relaxation prior to induction, ondansetron as an antiemetic, clindamycin, antimicrobial, and heparin used for thromboprophylaxis before the patient was then sent to the operating room for the first incision. So when we look at induction in the operating room, the patient was placed supine on the table, and according to the American Society of Anesthesiologists, they have these different standards. One of the standards is that patients must be undergoing oxygenation, ventilation, circulation, and temperature to be continuously monitored throughout the case. And so there was placed a non-invasive blood pressure cuff, an EKG, oxygen saturation was being monitored, train of 4 for neuromuscular contractions were being monitored, and tidal CO2 and a temperature probe was placed. This is all very standard for anyone undergoing an operation. The induction agents that were used were propofol and ketamine. Ketamine is unique in that it does help maintain respiratory drive compared to propofol, which is probably one of the reasons it was used in this case. And then the paralytic of choice was rocuronium. Fentanyl was used for an analgesic and also to help blunt the stress of induction. And then lidocaine is used for sometimes when propofol is being induced, it can cause a very painful burning sensation. So lidocaine helps blunt that burning. The airway was secured and anesthesia was preserved with the gas sevoflurane. And the anesthesiologist had achieved a standard tidal volume of around 500 milliliters, a respiratory rate of 13 to 17 breaths, and positive end expiratory pressure of 12. Everything looked good from the anesthesiologist side, and the OK was sent to the surgeons to begin operating. So the surgeons were able to get into the pneumoperitoneum about 30 minutes after anesthetic induction. This was done using a commonly used varus needle insertion within Palmer's point. This is located on the left upper quadrant, about 3 centimeters below the costal margin on the mid-clavicular line. You can see right here, this is Palmer's point. This right here is the varus needle being inserted. And you can see here what's happening during varus needle insertion. You usually hear around 2 audible clicks through the fascia and through the peritoneum. Once the varus needle was inserted, the correct placement of it was confirmed with a successful saline drop test, and insufflation of carbon dioxide was started at low flow and low insufflation pressure was observed. After adequate pneumoperitoneum was established, a small stab incision was placed in the midline for the port for the surgery to begin. Pardon me. And at this point, the anesthesiologist noticed that end tidal had plummeted from 30 to 9, and suspicion for a gas embolus began. Here we have a table showing you some of the metrics during the case. So on the left side here, we have the time. You can see baseline levels, and tidal was at 35. Blood pressure was 150/97, heart rate 71, and she was satting at 96%. You can see it was at this time the first indication that a gas embolus has occurred is that end tidal CO2 had dropped from what its baseline was, 35, to 9. And then you can see over the next few minutes, they started to see blood pressure dropping as well as heart rate and SpO2. So then the question is, okay, well, what was the response from the medical professionals in the room? So the response with the CO2 embolism is really the goal is to maintain support for the cardiovascular system, to maintain perfusion until the emboli can be resolved or dislodged from where it is. This typically involves supportive care, usually 100% oxygen to help displace the CO2, and sometimes, if it's available, hyperbaric oxygen therapy. The response in this case was that the pneumoperitoneum was rapidly evacuated, the port was removed, and the patient was immediately placed in the left lateral decubitus Trendelenburg position. As we mentioned, oxygen was increased to 100%, and they were working on getting an A-line for fast medicine induction, but they actually weren't able to get to arterial lines, and it wasn't until the third time that they were able to get an A-line into the femoral artery. ACLS protocol was started on this patient with 0.1 milligrams of epinephrine administered 4 separate times. Atropine was administered twice, and norepinephrine was administered. This occurred over the following 20 minutes. So thankfully, about 16 minutes, between 16 minutes after the first initial steps of the protocol was started, vital signs were able to return to baseline. As you can imagine, that was a big relief for everyone in the room. The patient remained intubated and then was sent to the ICU. There they did a chest x-ray, they did an echocardiogram, and they did arterial blood gases, which all of those did confirm that a gas emboli had occurred. The patient stayed in the hospital for 2 more days and then was able to be discharged. The next day, after her discharge, she actually came back and the Roux-en-Y bypass was completed without incident on a second attempt. They did use a different, they went for the varus needle insertion. They, instead of going in on the left side at that Palmer's point, they did go in on the right upper quadrant the next time. And one thing that was of note was that during laparoscopy, they did notice that the patient had extensive hepatomegaly that had not been known before. And she was then discharged home after the procedure. At her 1-week post-op follow-up, she presented with, the expected nausea and some mild abdominal pain from the surgery, but no concerning signs or symptoms. So overall, best case scenario, the emboli was able to be dislodged. She was sent to the ICU for 2 days, able to be okay, went home, and the next day had her procedure done, and no signs or symptoms that were concerning afterwards. So there's a lot of different considerations that we can look at and learning points from this case. So overall, not even looking at laparoscopic surgeries, but just any sort of surgery, a patient who's obese requires different considerations prior to undergoing anesthesia. One of the main things is that obesity is associated with a 30% greater chance of difficulty during intubation. A lot of this is just due to fatty deposits in the oropharynx, as well as increased work of breathing, higher respiratory demand. They have impaired cardiac contractility and often a ventilation perfusion mismatch. So the stress of a venous air embolism tests the cardiovascular system of all patients, as we know, but this is compounded on patients who have obesity, making it particularly concerning. And so all of this is relevant to all bariatric surgical candidates. However, specifically when concerning laparoscopic procedures, extra precaution and suspicion for embolus should occur during venous needle insertion. I also attached here a table. This is the ASA classifications of patients undergoing surgery. And so an ASA class 1 is going to be any sort of healthy patient, all the way to an ASA of 6. This is someone who's been declared brain dead. And so just based on this patient's BMI of being greater than 30, this automatically places them at an ASA of 2, which is probably what this patient was going into this case, considering that she didn't have any history of severe cardiovascular or pulmonary disease prior to this. So as we were saying, precaution needs to be, and suspicion needs to be, you need to be vigilant during this aspect of the case, because this is where 60% of symptomatic gas embolisms occur, is during the insufflation process. And so you can see the reason for this is because the inferior vena cava can easily be damaged during the insertion. So we have the insertion here. Now this is towards the end once insufflation has already occurred properly, but you can imagine that when the abdomen is right up against the intestines, that there's a lot of room for error to occur. And a lot of times the signs of trauma are not evident to the surgeon. And so it's just another precaution for the anesthesiologist to maintain awareness on those monitors, even a few minutes after insufflation, as was done in this case, where they immediately noticed that the end tidal was dropping and started having that conversation. Now, another thing to consider is that varus needle liver puncture is also suspected to be another leading cause of gas emboli during laparoscopic procedure. So the large size of the liver actually makes it a easy target, while the parenchyma around the liver prevents complete vascular collapse. It does allow for gas uptake. And as we know, bariatric patients are at increased risk of hepatomegaly, and this should be a consideration for patients who are undergoing laparoscopic surgery. Now, uniquely in this case that we talked about today, they didn't know that the hepatomegaly was present until the second attempt when they were able to go in laparoscopically. So is this something that maybe should be considered in the future to have an ultrasound or confirm the size of the liver? That's something definitely to be thinking about. Another consideration is to avoid using Palmer's point as was done here in the left upper quadrant, and instead use something called Jane's point, which is not as often used. But as you can see right here, Jane's point lies to the left side of the abdomen at the L4 level. It's about 10 to 13 centimeters lateral to the umbilicus and is indicated for patients with hepatomegaly. And so further varus needle insertion under ultrasound guidance has been used in individuals with increased abdominal adipose tissue to avoid puncturing large vasculature or solid organs. So a combination of Jane's point with ultrasound guidance might be something that it can help prevent this situation in the future. But as you know, unfortunately, no method completely eliminates the risk of gas emboli, as evidenced in our case where there was attentive varus needle insertion. There was verification with the saline drop test, and there was low peritoneal pressures used, low flow used, and still it resulted in a life-threatening gas embolus. So the question then is, after these considerations, well, if this still occurs, what is the correct management? And as we kind of mentioned, the vigilance of the anesthesiologist is key, because the first sign of an acute carbon dioxide emboli is the dramatic drop in end tidal volume. And so this can be managed by discontinuing insufflation altogether, placing the patient in the left lateral decubitus position. By placing them in this position, it traps the emboli on the lateral wall of the right atrium. You can see this position is the left lateral decubitus. Additionally, we can do a Trendelenburg position. Now, this actually, depending on who you talk to, can be controversial in patients with obesity, because it does put greater pressure on the respiratory demand. In our patient in particular, if you recall, she did have a previous attempted surgery back in 2012 where they attempted to do the hysterectomy, but it wasn't able to be a success because she couldn't handle the Trendelenburg position because of the respiratory insufficiency. And so I don't know if that was ever something that was talked about prior to this case, but it's definitely something to think about if Trendelenburg is already a controversial position, or a compromising position, I should say, to put someone who has a large BMI. Then maybe patients who have shown that they've had an issues with that in the past, it should be avoided altogether. On the other hand, a gas emboli is extremely life-threatening, and so you're trying to preserve, get that patient breathing and ventilation and perfusion as much as they can. And so definitely different areas to consider. But it's just interesting that they had placed her in that position, despite the previous history of having a difficult time. So moving on with the management, you want nitric oxide to be completely discontinued, as it can accumulate and draw the gas embolus into pulmonary vasculature. The patient should be placed on 100% oxygen. This helps encourage the washout of the emboli and can help correct the hypoxemia that we're seeing. Medications used in a suspected venous air embolism are generally supportive measures to maintain hemodynamic stability. Common ones seen are norepinephrine, which helps maintain ventricular function without causing further constriction of the pulmonary vasculature. Prostaglandin analogs and phosphodiesterase inhibitors may also be useful in reducing pulmonary vasculature pressures. Milrinone and dobutamine are tested options to improve contractility and manage the afterload. A lot of times just because the air embolism can pose a risk of cardiac arrest secondary to acute dysrhythmias. I always have trouble with that word. Which is interesting too, that during embolism like that, you need to also be considering, okay, what is this patient's heart rate looking like? What is the rhythm looking like? Because you don't want to have a secondary issue like that. Furthermore, you want to initiate ACLS or advanced cardiac life support protocols. Establishing an A-line for rapid medication effectiveness. And this was something that we actually had seen when we were writing this paper up and doing a little bit of a literature review. It's not commonly used, but you can do a placement of a central venous catheter or a pulmonary artery catheter. This allows for aspiration of up to 50% of the entrapped air in the chambers of the right heart. However, an emergency central line in this case is already going to be more challenging with someone who has a larger body mass index and is extremely, in a case where it's extremely time sensitive, it's probably not going to be a first line measure, but it was something that I thought was interesting to bring up. So overall, when we're looking at this, as we reflect upon this case, the medical team implemented a lot of excellent measures, including administering heparin prior to surgery for thromboprophylaxis. They used a great selection of induction agents with a combination of ketamine and propofol. They maintained low insufflation flow during the procedure. And then after varus needle insertion, they stayed vigilant. They immediately noticed a drop in end tidal CO2 and acted quickly to remove the ports and reposition the patient into that left lateral decubitus position. Now, there are a few future considerations and key learning points from this case, including just the consideration of Jane's point for varus needle insertion in bariatric patients, specifically with hepatomegaly, alongside the utilization of ultrasound-guided imaging to enhance the precision of the procedure. And along the lines of the ultrasound, it could be beneficial prior to surgery when you're looking at the surgical candidacy of this patient to see to just get a confirmed liver size if you're planning on using Palmer's point as your insertion. It's unclear completely if there was a discussion about the patient's previous difficulty in the Trendelenburg position, but definitely I think considerations there are crucial and should be integrated into preoperative planning. Furthermore, the challenge associated just with placing arterial lines in patients with increased adiposity underscore just an importance of having a tailored anesthetic strategy for the demographic of patient that you're working with. Now, these future considerations, not all of them are mandatory interventions, and they definitely hold significant value and definitely merit consideration when performing laparoscopic procedures on bariatric patients. I believe a lot of these things were done by the team ahead of time. It's just when we look back and we look at what areas are there for improvement, what could have been done differently. These are a lot of the things that come up, especially just with the A-line, having 2 failed attempts and then finally getting one in the femoral artery. Would have been beneficial to have an A-line beforehand. In this case, yes. But an A-line comes with its own contraindications, and it's an incision. It's an area for potential infection. You don't want to do that to every single patient. So a lot of things to think about and talk about. I appreciate everyone listening. We talked about a lot of ground during this presentation. We looked at the background and significance. We were able to you're able to hear about this interesting case of a 42-year-old woman undergoing laparoscopic surgery and incidentally getting a gas embolus. We looked at the anesthetic considerations. We looked at what preventative measures can happen. What is the current standard of treatment and management when this occurs? And so I really appreciate it. This is a quick list of my references. And thank you very much. Does anyone have any questions or comments?
Great presentation, sir.
Thank you.
I appreciate your slides and the way you, the mechanics of your talk was excellent.
Oh, good. Thank you.
You mentioned this was a case study. Is this published?
It's submitted, pending, I guess I would say.
Well, if it gets published, please let me know, and I can provide some support and distribution of such a
awesome
interesting case study. I mean, it's kind of mind-boggling what happened there. So I could actually hear the sound of the relief of the folks in the operating room when she came back to you.
Yep.
I was on pins and needles myself. So I have a question about the hepatomegaly that was not, you mentioned it was not realized initially. Is it possible that it was iatrogenic? In other words, do you think her liver got poked and swelled up?
100%. I 100% think that that's a very valid thought. Is there a way to know? I don't know. But I don't think that someone. I think it could be either way. This person could have just had a larger liver beforehand. They could have had something wrong with it that was just asymptomatic that no one knew about. Or it was 2 days before, so there still could have been inflammation from the liver from it getting poked. And that's where you just want to think about what are some alternative insertion points for bariatric patients where they might be at higher risk, just because maybe, to your point, maybe the liver's a normal size, but when you just have that increased adipose tissue, getting the needle exactly where you want it to go is a lot more difficult. So in that case, maybe you still use that Palmer's point in the left upper quadrant, but maybe you use an ultrasound to guide it, just to be sure you're exactly where you want to go. But I think that's a very valid point and thought to have.
Also a good argument for using, I guess you called it the Jane's point, something a little lower.
Exactly.
By the way, you're talking to someone who's done IP injections in a lot of rodents, many rodents, and it happens from time to time that you poke the liver. Sometimes the mice don't like that at all. So, Dr. J, go ahead.
Donald, excellent presentation. Never had a case like this, and want to say thank you for how you presented it and explained your slides and the physiology at the same time. And so I've got 3 or 4 questions, and one thing that is a hard thing for me to buy into is the size of that liver didn't get that way overnight. The patient has morbid obesity, and the fact that, and it's easy to critique it in hindsight, that you could hide a bowling ball in the belly, and somebody that obese, you can't feel it. So the likelihood of palpating and the size location of the liver is pretty darn hard at the bedside pre-op. That much morbid obesity. So I'm a hard sell to buy into the fact that your first insufflation was on the left side in the upper portion, let's say below the rib cage on the left side. And then your second approach was at a later time, I guess, more in the midline. So I'm not saying it didn't happen. I'm not an expert on that. But if it did happen, you, in your opinion, you feel that that is the most logical likelihood of this source? Because you did say, or as you insufflate the peritoneal cavity, it will resorb. That's where else is this supposed to go? So that's my question. I've got a couple of questions for you, and I'm not done yet, but go ahead. So if right, where's it supposed to go?
Where is what's supposed to go?
The CO2.
The CO2, well, it usually sticks around there and stays and kind of provides that the density of the air kind of pushes the intestines down, pushes the abdomen up, and it keeps that camera there, so it stays there. In regards to, I agree. I think there's no way to know exactly what happened, and that's partly what makes this case so interesting. I think that I think there is a strong point to what Dr. Staudinger said, that okay, maybe the liver was nicked on the first go, maybe not to a degree that immediately the surgeon knew, but something just small enough for a little bit of that air to get into and lead to this. Was the liver already large? Well, in this patient, yes. Was it considered, was it symptomatic hepatomegaly? It doesn't look like it that we know of. But was that maybe just nicked enough of that first time? I would say that's probably my most likely hypothesis of what happened. But it is impossible to fully know.
Yeah. Okay. All right. I'll buy that. There's still an aura of we're uncertain. And
exactly.
That's okay. The other question is that she had an ACLS type of protocol initiated when things were going south. She received 4 doses of epinephrine and 2 doses of atropine and some norepinephrine. What did the cardiac monitor show during that period of time?
Are you talking about like what was the rhythm strip looking like?
Yeah. Yes.
I wasn't there. So I don't know exactly. I wasn't able to see the
okay.
The anesthesiologist screen is usually recorded throughout the whole case, but what we were able to get access to when writing up this, we weren't able to see all of that. That's why I wasn't able to know the baseline blood pressure of the patient beforehand. I mean, if they're giving those I don't know. I don't know exactly what that strip would have shown.
And that's okay too. The anesthesiologist's record will show it. He'll say on there, he or she will say on there, bradycardic asystole, whatever the rhythm disturbance is, because you just don't give epinephrine for an uncertain reason.
Right.
So what I would ask you to do is try to find the record of what the anesthesiologist was marking down as to what were the indications for 4 doses of epi and 2 of atropine. Atropine, you can easily rationale for Brady arrhythmia. And the epi, you got to be thinking no rhythm or very, very, very something's really serious going on.
Yes, I do.
Those vital signs that you showed, you had no blood pressure. You couldn't detect a blood pressure, or at least one recorded, one charted. So I'd like to know what the rhythm was.
Yeah,
really went south.
I do know that the ACLS protocol involved in it is epinephrine, depend on what's going on. So you're giving, I think it's like first the two doses that you gave epinephrine, then you switch to atropine, and then you go back to epinephrine, then back to atropine. And so because they did that over 20 minutes, I assume that's why there was 4 doses given. I don't think they were given one after the other. The 2 doses of atropine, I believe, were in between the doses of epinephrine, because I believe that's how the ACLS protocol with the new updates have been. But I do agree with what you're saying. It would be nice to include what that rhythm was showing during that time.
Yeah. And the last couple of things that I've got is that with that large of a patient, it's very, very difficult to feel any landmarks in the neck, the head, or the shoulder area, the clavicle, etc. So a central line would be tough.
Oh, yeah, 100%.
So that would be almost something that would just luck would have it that if you hit a liver one time, maybe you could hit the center, maybe you hit a vein, but it would be very, very difficult to do that. My last comment is, what was the disposition of the patient?
What do you mean by that?
Did she walk away? Did she go home, or did she go to the morgue, or what happened?
Oh, I see. Yes. So she, they took her to the ICU after they were able to get vital signs back. They kept her intubated. They took her to the ICU. She was in the ICU for 2 days until they were confident she's able to go home. She was discharged that second day, and then they had already rescheduled her Roux-en-Y for the following day. So she was in the ICU for two days following the gas emboli.
Okay.
And then she was discharged. Then the next morning after discharge, she came in for the surgery, and surgery went successful. Wow. And she walked away asymptomatic from that case.
Yeah, I think you did cover that. Again, outstanding presentation. Well, just very knowledgeable about this, and I appreciate it very much.
Oh, thank you very much for your questions.
Thank you for sharing.
And the best presentations always raise many questions. And I'll say one more thing. 2 things, actually. This is a good argument to watch your diet and do a lot of exercise while you're still not morbidly obese. That's exactly the take-home message for me, per se. So I'll go ahead and ask Dr. Wolf. Go ahead, Dr. Wolf. You're muted, sir.
I am. I'll say as well that, yes, I enjoyed your presentation very much. You did a great job. As I was sitting and thinking about this, a couple things crossed my mind, and that is, if somebody is that obese, they got these big rolls of fat laying on their belly. Could you not potentially come in there if you've paralyzed them? Couldn't you potentially come in there and pick up on that fat and try to create a little space between the guts? I mean, if I would sit there, if I had a rat anesthetized, I would always sit there and pick up on the abdomen so that I knew for sure I could stick in a sharp needle without doing some damage. And because my guess would be, I mean, you got everything squished down And now you're coming through, and I didn't know what that varus needle was either. I just looked it up in Wikipedia. That's a cool thing. You may want to describe that to people, but I'm going, okay, well, the instant you pop that sucker through, there's going to be tissue right underneath that. And it's that instant right there that you need to protect against. And if you could just create a little separation physically, it seemed to me that your problems would be less. But I was going to, the problem of trying to find those points to begin with, when there's so much fat. I worked in a nursing home once and took care of a woman that was morbidly obese like that. And oh my goodness, there was rolls of fat all over the place. And how you could possibly find anything is beyond me. But that was the big thing that I thought of was, why don't you just pick up on it?
Yeah, that's a great point. And a good point too about this, maybe take it next time if I present this again, we're talking a little bit more about that varus needle, because that too, to me, was something I wasn't familiar with. Now they do exactly what you're saying. Once the patient's induced, they identify where they want to put, they mark it with surgical marker, and then they'll actually pull up, and I can include an image maybe next time of that, because they do pull up on that skin, and then just to provide, like you're saying, a little bit of dead space right there, or just room there to place the needle, which is, as we mentioned in the beginning, this is not something that commonly occurs, and part of that is just the improved skills and technology with robotic surgery, and how that happens. This just so happened to be one of those 0.001 times when that little bit of gas got where it wasn't supposed to, and it does bring up the questions. Okay, what are some things to take away from this? What are some considerations? But exactly to your point, that's where 60% of the symptomatic gas emboli do occur, is during that exact moment when you're inserting that varus needle. So thanks for bringing that up. And definitely, if I present this again somewhere, I'll definitely include a little bit more about that, because I think that is a key thing here, and something that I wasn't familiar with when I first was a part of the case, and something that I think would be beneficial to the viewers next time.
Well, hopefully I never have another surgery, but if I do, student Dr. Keating, I hope it's you putting me under.
Oh, thank you.
Are there any other questions or comments? There's a couple of comments in the chat. So one would be, do internal organs absorb CO2 under pressure in the body cavity without being nicked and cause embolism ever?
I would assume to some degree the body's constantly circulating, and that air's got to go somewhere. And they do consistently put more in, so it's being absorbed. Now, is it being absorbed into the bloodstream directly? No, not in the same way to where it can cause an embolism like this, unless some damage occurs.
Right. So that's an argument for a nicked liver or something like that, allowing the
definitely something happened, something that was not supposed to be damaged was damaged, and caused this. And so I think the reason for the liver that's so interesting is that on that second look, they noticed some undocumented hepatomegaly that they hadn't seen before.
And how did they notice it the second time?
Well, they went back in. In, and laparoscopically we're performing the gastric bypass, and they see the liver there, and they say, this is larger than.
I see. So
it
wasn't like they screened for it. It was just once they went in the second time, they're like, whoa.
Exactly.
That liver. Holy crap. Okay. I'd also say it's pretty clear that why anesthesiologists have a high liability in malpractice insurance. Anytime you're doing that much invasion into any patient. Wow. You have to have nerves of steel to be one, for sure. Okay, any last questions or comments from anybody?
That's supposedly your purest form of pharmacology in practice.
Yeah.
That's what's great about it.
Yeah, and the amount of pharmacology you listed in this presentation was significant. Okay, without any further ado, unless anybody has any comments, speak now. All right, Dr. J, thank you so much for being a loyal, and you too, Dr. Wolf, for showing up. Dr. Creamer, appreciate you guys very much.
Nice job.
Nice job. Great job.
Thank you.
And you'll see your recording here probably by the end of the day.
Oh, great. And thank you for having these